I forgot this is where it was, so I didn't grade anything. And then I asked Dick, where these sheets were. He said, no, I'm not doing any grading either. Chris is telling you.
I did just.
They are grading. Well, I'm gonna catch up. Though.
Yes, if you think that-
I didn't remember. I think you showed this to me right as I walked in.
Yeah, you were saying.
But I thought there was a straight piece of paper somewhere.
And I just remembered that as you go.
Okay, but how do I tell?
That's paper. Right. This is actually.
I thought that was a great session. That was a big test. I kept on that.
It sounds like you weren't the only one. We're a little late. But that's good. That's good.
That's my philosophy.
In fact, it was gonna ask, when I need to start bringing people back.
Yeah.
Okay.
Time is. And he's in the big room.
Yeah, I saw it.
Yes, yes. Well, yes.
Yes.
Are you? And you're from the Netherlands? Is that right? So you're taking over the.
They were trying to.
So is Mark Best like really as nice as he seems, or is he getting a little damaged? Really? Yeah, I've known him for, I think he's great. Yeah, yeah, I heard that. He's a great friend. I've known him. Great. Try not to beat up on you. No, it'll be great. I'm super excited. Yeah. Yeah, great to see you. I've been joking that this is like me and meeting your statue on the planet. It's amazing. It's been fun to share. Yeah, this has been great. What we usually do is just go back and forth. One day you want to meet. Yeah, that's all right. Great to see you. Yeah. Oh, yes. Yeah, yeah, yeah. It's great. So, oh, no way. Oh, I would love to chat about that. That'd be great. And you're still doing well? The student's 91, but that was such a memorable visit to us. I am fortunate not no longer seeing that. Okay, I don't think you speak of me. She's all around. I don't know. You know that's. But anyway, I would love to chat. So I'll find you out. It'd be great. What? You're still like, no, I recently retired. Yeah, but I'm looking at other things. I sort of was told to retire. So I know they do that at band. So I'm sort of middle of the summer, I put the fact that I was reading it on LinkedIn. Yeah. Since then, I have about 300 messages. So I've decided I'm gonna probably change it. Through my career, if I was on it, I was assigned to a committee, I talked to them, just making the chairman. So I had expertise on all these other non-circuit with them. So it's not a bad thing. No, it's not. I guess I could be anything. Whatever you say. Well, get in touch with me. Yeah, I can let you know my personal email. Yeah, let's chat then, that'd be great. Which one do you want, like, number one or number two?
I can just take it.
Yeah, let's go back.
I'll do all the emails.
Okay.
You kind of start the session.
Yeah, let's go. And just so you know, they have.
How are you? So good to see you. I'm so excited to see you. I don't get to see you enough. Thank you for taking care of, Jenny. She,
She is very.
I'm expecting her to stay up with that.
I said, now it's.
So as a reminder.
Yes.
On off there. Oh, red is on?
That danger, say it, yeah. Got it.
Well, anyway, this is a little thing that's kind of. People give the announcement of their. I don't know, but years, I get assigned, we have a conference call, and they have all the grades.
By yourself? I did. You did? No, you know, Mayo discourages that with business. So I fly everywhere myself.
They don't want to share their most valuable service.
Well, you know, it's because they used to.
Yeah.
But then. Mayo now is not. Any business related trip.
You know, I told you down my. Sure, I don't love it. I actually pronounce it. You know, I'm working on flight school, middle river aviation, so I've actually jumped in and I started doing it. Yeah. So I need to get the 60 air hours to get my, license. So that's the biggest thing, but it's fun. It's like a side job 72 weeks ago, just coming in.
Just for fun. It's just so fun to learn. It's safer. Well, so that's kind of a day job. So I can do a job.
Right. Yeah,
Well,
sure.
for sure do that.
Because it's like,
Your risk of mortality goes way in.
really?
Oh, yeah. We have,
Most of them, what, 50%? No, 28.
Most of the generation.
Almost. You know, I joke around and stuff like that. When it comes to that, anything sure, checklist, everything. And it's funny, there's a lot of similarities between that and certain. And I also more certified in and it's the same, it's just like the same thing. It can happen, you know.
Yeah, we thought.
I'd love to give it time.
It's an phase next year. Next year. We should like, we have to do it. That would be really interesting. It'd be so. Or like a dinner talk like.
Maybe I should, honestly jump into that. 15 years ago, they kept forcing everybody, every hospital to go, and maybe they're coming to train them. Well, good, all right, let me know how it goes.
Well, if I'm not here next year, you'll know. No, I gotta get the link, or, I mean, the way they want to get 60 hours.
You know what scares me?
But at this point, it's a system. It's not like it's coming.
We lost the cardiac surgeon limits about 3 years ago. And my chairman of cardiac surgery, whole friend of mine, trained me. We were talking about it. The worry is you don't. The next time you use it, I'd say it's 5 months later.
Well, it's hard, but you just have to do it. You just have to commit. You have to aim, fortunately, at least 40 hours a year. They have to be flying right.
You're not gonna say here, it's so disorienting. Have you ever had that feeling?
Well, in training, but now, no. Trust the instruments and not linear perceptions. And so that was part of the excellent training. But when I first started the training, we went into the clouds and said, okay, keep us on. And within literally 15 seconds, I lost the smile. It's bizarre.
Scary. All right, should we go? Yeah, let's go.
Welcome back, everyone. We're about to start our second session, which is on minimally invasive surgery. I can remember maybe 10 or 12 years ago when we had our first paper having to do with robotic pancreatic surgery, and I made faces and said, that's never going to happen, showing you how right I was about that. But anyway, I want to reiterate, and hopefully some of the future moderators will hear what I'm saying, but we already know some papers that are going to generate very little discussion. So we really hate to limit the discussion. If we have a paper that's generating lots of chatter, we're going to let you talk. And again, that's what I view as one of the great gifts, treasures of this meeting, is that we get to have everybody ask their question, and then we generate more discussion within the audience. The gem of this meeting is the audience. As much as we love the speakers, it's the audience that matters. Anyway, I'm co-moderator. My name's Bill Nealon. I'm a HPB surgeon. My partner here, I've been just joking with him that he's one of the LeBron Jameses of the minimally invasive surgery. And if you remember, he was doing laparoscopic Whipples when maybe 2 people on the planet were doing that. And now he's got into the all of this range. We're also, I know, empowered in this meeting room with a good number of really highly skilled, internationally recognized experts. And then there's me. But we're going to have a great session, and I'm gonna let Dr. Kendrick start us all off.
All right, welcome everyone. We will start off with an amazing paper. Dr. DeGraff will present minimally invasive versus open pancreatic duodenectomy for resectable pancreatic and periampullary neoplasms. Diploma 2.
Good morning, everyone. Thank you for the introduction. And I'm honored to stand here and to be able to present the results of the Diploma 2 trial to you, all the way from Europe. Let's see. We as a study team, we received a research grant from Intuitive Surgical to be able to conduct the study as financial support, and from the Dutch Cancer Society. So the safety of minimally invasive pancreatic duodenectomy is quite unclear. So when we started, I want to take you back 5 years ago in 2020, we had the results of 3 randomized trials. First 2 single-center trials from Spain and from India, which showed good results with a benefit in terms of hospital stay, as expected for minimally invasive surgery. And then we had the Leopard 2 trial, which was a Dutch trial, and it was stopped preliminary before the end by the safety board because of a 5-fold increase in mortality in the laparoscopic group. So we had 3 trials comparing laparoscopic to open surgery for Whipple, and the results were controversial. Then there was still a remaining question. So does minimally invasive surgery for pancreatic surgery for the Whipple offer benefits that justify the high cost, the learning curve that's associated, and the longer operating time? So we gathered as a research group with multiple centers in Europe from the EMIPS consortium, and we designed the Diploma 2 trial, which was designed to be an international multi-center trial. We started this in 2020 with many centers. With our main research question, is minimally invasive pancreatic safe as compared to open surgery? And then as a second main question, does it also offer the hopefully expected enhanced postoperative recovery? So the Diploma 2 trial, we designed it primarily as a non-inferiority trial with the primary endpoint CCI, so the comprehensive complication index, which gathers all the complications that were present in the first 90 days. And then as the main secondary outcome, time to function recovery with several criteria. And we also made sure that the total sample size of Diploma 2 was sufficient to assess, to perform a superiority analysis. Of course, we also looked at other post-operative outcomes, oncological outcomes, and quality of life and cost. And it was supposed to be a 3-year project. So here you can see the main outcomes of Diploma 2. So first, the CCI. As I said to you, we grade all the complications according to the Clavien-Dindo. Every patient that was included in the study also received a Fitbit watch to not only assess the post-operative activity during the hospital stay, but also up to 90 days after surgery. And we assessed the time to function recovery based on the criteria that were also used in earlier studies. We included patients with a primary resectable tumor, no vascular contact, a BMI below 35, and no chronic pancreatitis as an indication was included. And we learned from the Leopard 2 trial that we set some center and surgeon eligibility criteria. So the centers that wanted to participate in Diploma 2 needed to perform at least 30 minimally invasive Whipple per year before starting with the trial. And the surgeons that were performing the procedures needed to have an experience of at least 60 minimally invasive procedures to perform the minimally invasive procedures or 60 open procedures to ensure the sufficient experience in the trial. We randomized in a 2-to-1 ratio, so twice as much minimally invasive cases. And in total, we included 288 patients. We stratified for certain POPF risk factors, PDAC or non-PDAC as an indication, and robotic and versus laparoscopic surgery. And we blinded the patients up to post-operative day 5 to make sure that in the early days after the surgery, we tried to reduce the bias of seeing the scar. Also, we used the blinded adjudication committee to score all the post-operative complications. Then we were able to, 14 centers in all Europe were able to participate in the trial from 6 countries. And we included patients between the beginning of 2022 and after 1.5 years, we reached the total amount of inclusions, which was faster than we expected. Then the results. So here you can see the baseline characteristics. There were no differences between the 2 groups. And we included also patients who had received a neoadjuvant therapy, but only a few. So in both groups, 6%. Then here you can see the surgical characteristics. So we found a conversion rate of 8% after minimally invasive surgery. 90% of all procedures were performed robotically. and the other percentage laparoscopically. We found a reduced operative time, of a longer operative time after minimally invasive surgery, and reduced blood loss. There were no differences in the arterial resection between the group. And here you can see the primary endpoint of the trial. So the CCI score up to 90 days, and we did not find any differences between the groups. So the non-inferiority was hereby significant. Then here you can see the median time to functional recovery. We found a 1 day shorter time to functional recovery after minimally invasive surgery. And we found also 2 day shorter hospital stay after minimally invasive surgery. And with quite a high readmission rate, which was not significantly different between the two groups. So normally in this presentation, I also show the results of the Fitbit that the patients wear during the study. But my colleague, Caro Bruna, is presenting these results in the following presentation. So then also some other secondary endpoints, the complications. We did not find any differences in the major complications, Clavin Dinder grade 3 or higher. The mortality after minimally invasive surgery was 4.7% versus 2%, which is different, but it was not significantly different. And we did not see any differences in re-interventions, percutaneous drain replacements, surgical interventions, or and also not in ICU admissions. We found a quite unexpected lower fistula rate after minimally invasive surgery. So 23% versus 36%, which was significantly statistically significant. And also reduced surgical site infections as expected as after minimally invasive surgery. No other complications were different. Also, we did not find any differences in the quality of life from baseline up to 6 months after surgery. And also the cost, we calculated the cost including the Da Vinci system and also excluding the Da Vinci system. And also the overall costs were not different between the groups. So what we found was, of course, a higher cost during the surgery. So the intraoperative costs were higher, but the reduced post-operative costs because of the shorter hospital stay and the reduced fistula in the minimally invasive group balanced the total cost. So if we add the Diploma 2 trial to the currently existing RCTs that are currently published. So in the beginning, I showed you the 3 trials that were available when we designed the trial. Now, at the moment, there are 2 laparoscopic versus open trials added to this, which showed small benefits in terms of hospital stay, but no benefits in terms of complications. And also 2 trials who compared only robotic versus open surgery. And so we have the trial from Klotz from Heidelberg, which is a pilot trial with only 62 patients who actually failed to give us some positive results for the robotic group, which showed a higher pancreatic surgery specific complications and also no benefits in terms of hospital stay. And the trial from China, who actually had the same results as the earlier laparoscopic trials. Then what we can conclude with the Diploma 2 trial in the beginning is that we found a lower fistula risk. We found a shorter hospital stay, benefits in time to functional recovery, although the mortality was higher, although not statistically significant. The trial also has some limitations. We used a pragmatic design. It is an international multi-center trial, so you also always have the differences in the procedures, the differences in the hospital perioperative care. We tried to standardize the post-operative regimen for the in the study, but of course it's difficult if you work with so many different countries. On the other hand, it does reflect the real life practice. One other limitation is that we were not able to blind the outcome assessors of the primary outcome. We try to minimize this minimize this bias using a blinded education committee. And I want to add another limitation of the study is that our results are reflect the practice of high volume centers with expert surgeons. So it's difficult to extrapolate these findings to lower volume centers. But we can conclude from Diploma 2 that minimally invasive pancreatidylectomy is non-inferior to open pancreatidylectomy in terms of overall complications, and also is superior in regarding the time to functional recovery. So based on the Diploma 2 results, we believe that it can be offered according to the surgeon preferences in these subgroup of patients. So further research is now ongoing because we continued with the Diploma 2 trial as the Diploma 2x2 trial, which is an oncological trial. And in this study, we want to more focus on the oncological outcomes. Our seroresections, the time to adjuvant therapy, the completion of adjuvant therapy. And my colleagues, Caro Bruna and Julia Menso, are coordinating this trial, and also some USA centers are participating. So I'd like to thank all the centers for their participation, and I'm happy to answer any questions from I'm happy to hear what your opinion is on the results.
Thank you. Well, just briefly, Dr. Kendrick's going to lead the discussion, but I want to mention this is a paper is eligible for best paper.
Yeah, thank you.
you.
Thank you. We'll take some questions. Dr. Vollmer.
Yes, hi, great talk, great stuff. I'm going to contend, although you had this disclaimer, that this is not real world practice, not real life practice. So just a fact is that half the people in the world doing pancreatidodenectomy have not performed 60 Whipples in their career.
Mm-hmm.
So you have these people that are doing 60 a year, right?
Yeah.
Who of both, these are the highest high end of technical proficiency. And the concept that people are going to do 30 minimally invasive cases over their career is pushing it for most people. That's the problem, is that what we really need to know is what's the safety on the ubiquitous level of everyone who's getting on and doing this at the outset. And that's why I would ask, what is safety actually?
Yeah.
This concept of, is this trial to say that this is a safe technique? What is safety? It's a very, very nebulous term.
Yeah.
And then the second point I'd make is that, you look at the length of stay thing. That is a very big outcome that we say kind of tilts towards the MIS. But American lengths of stay are 7 to 8 day medians. And these are just getting to that point. And I think that when that's the median level, it's going to be very hard to take that down and show that it's a better kind of thing.
Yeah.
The European numbers are 17, 18, 20 days down. So I think these are two drawbacks to this, but I applaud the work nonetheless. Thank you.
Yeah, to get back to your first comment regarding the experience, I think it's quite difficult to design a proper, well-designed randomized trial. And actually, we wanted to create like a controlled environment. We wanted to really assess the effect of minimally invasive surgery versus open surgery. And in my opinion, I think you need to handle, you need to add these experience criteria, because otherwise you introduce too much bias from maybe surgeons that were not sufficiently experienced. So after Leopard 2, there was a lot of confusion, like, should we continue with the minimally invasive approach? in the Netherlands, the laparoscopic procedure was stopped. Nobody performed laparoscopic Whipples anymore. During the Leopard 2 trial, there was already a training program for robotic surgery, and there was like, okay, should we continue with this or not? That's the rationale as after of the Diploma 2 trial. So that is why we audit the experience criteria. I do agree with you that it's difficult to extrapolate this to the real life, real world practice. On the other hand, I think it's good to also use this information that maybe because of this experience criteria, we were able to detect some benefits of the minimally invasive approach. And then we can, well, it can create a discussion, do we need to centralize with the minimally invasive procedures to make sure that each center, each surgeon has sufficient experience in this. And regarding the second point on the hospital stay, I do not really like hospital stay in trials as an outcome measure, especially not when you're working with multi-centers. We're working with different countries. Netherlands is different compared to Italy, to Germany. So that's why we also introduced the time to functional recovery as a more objective outcome measure. It's difficult to find benefits in the randomized trials. Yeah.
Thank you. And just in the interest of time, we'll get to these four people, but just we can keep the questions very brief and the answers very brief as well. Let's go this side.
Yeah, Brock Hewitt here, NYU. A fantastic study, guys. So just really briefly here. So now say you have a patient that's coming in based on your data here, what's going to be your recommendation as far as open versus, robotic in these types of cases? Saying you have it.
So in our center in Amsterdam, all patients who fit the criteria for Diploma 2, so no vascular contact, primary resectable disease with or without neoadjuvant therapy will be offered robotic surgery. Yeah. So and actually I forgot to mention it, but all the centers in Diploma 2 changed to robotic surgery. I think in most of the centers they will continue with.
This has changed your
It
standard.
has. Yeah.
Yeah, Jing He from Johns Hopkins. Nina, wonderful work. For your 190 patients in the minimally invasive group, how many patients meet the Brescher's consensus definition of robotic Whipple? Or you have many different, combination, different way to approach robotic Whipple? The second question is, your data showed longer OR time, which is different than the Chinese trial.
Mm-hmm.
And I would say most European surgeons doing two surgeons, robotic approach.
Yeah.
It's really hard in the United States to push for two attendance case, longer OR time. So financially, it just doesn't make any sense. So how do we, convince this pancreas club in the United States to push for the robotic approach?
So you're right that in Diploma 2, the centers use different ways to do the robotic procedures. So some use the one surgeon approach with an assisting nurse, and other centers, all of the Dutch centers, use the two surgeon approach with also a tableside surgeon assisting with the laparoscopic instruments. So most of the procedures were performed with a two-surgeon approach, and we did not perform any sub-analysis on this yet, but these will be added to a different paper. And regarding your second question regarding the operating time, right? And so what we see, I can speak for the results of Amsterdam, because we analyzed also the reduction in time after the certain procedures. So at the moment, we see a large reduction in the operating time using the two surgeon approach. I cannot really speak for the results from the one surgeon approach, but in the Netherlands, we do think it's beneficial to use the two surgeon approach, even if and also because of the reduced surgical time, and that's make sure that you can do two procedures in one day.
Thank you. Dr. Pitt.
Henry Pitt, Rutgers. Nina, very nice presentation. My question has to do with the pancreatic fistula rate. There were 23% and 36%, overall high 20%. In North America, in the NSQIP platform, where we have the vast majority of the Whipples being done, our rates are half that, 14% max. So what's the explanation for why the pancreatic fistula rate was so high in this study?
Yeah, good question. It's also something that we were wondering. It's something that we were already wondering for a longer time, and that's why we also collaborate with you, with the many centers in the US, to see what are the factors that create these differences. We actually do not know yet, but my colleague Julia Menso is also working on the TROPRANK project, and to see if there are any differences in surgical technique, in post-operative care, drain placement, these kind of things, to see what is causing these differences. So I do not have the answer yet, but hopefully we will soon.
So if I can just interject there, I don't think we should ever be talking about fistula rates without talking about what the fistula risk score was,
Mhm. Yeah.
right? Because before we start looking into technique, let's just look, is it more, are these patients more likely to have a fistula risk score of 8 versus 3
Yeah,
or
what
something
was the
after neoadjuvant
pathology, for
therapy?
example?
So I would just encourage you in the manuscript to please insert fistula risk scores.
Yeah, we have also analyzed this in the manuscript. We did not see any differences between the groups.
Okay,
So
no,
the-
that's great.
yeah,
I think,
yeah.
but that's the first question that
Yeah.
I always ask when someone's trying to compare
Yeah.
fistula rates is what is the risk score? Because that has to be kind of the basis before you talk about it. Last question, thanks.
Declan Fleming, Austin, Texas. I think it's interesting that again, going back to the fistula, the incidence of mortality was higher in the robotic surgical group.
Yeah.
And if you look at the numbers, 5%, that's about 10 people, right? So you must have had the opportunity to look at how they died, when
Mhm.
they died, all the rest of that. Was there a trend in that? Were people dying early for bleeding? Were the fistulae not recognized as well, so there were complications from it? Was there anything to be learned from that?
Yeah, so we looked into this in detail because we were also quite worried about it, especially after the Leopard 2. Also, the safety board closely monitored our outcomes, and so after every 25 patients, we had to hand in like the details of the patient who also died. We looked into this. We did not see any intraoperative deaths in the study. Also, there was no real trend regarding early complications, for example, the bleeding, that were, in our opinion, related to the surgery. So we could not find any trend in this. So yeah.
All right, very good. Thank you.
Thank you.
Thank you very much. Appreciate it. I realized when I was asking everybody to encourage discussion, I should have mentioned that the speakers have to really be careful. If you eat up 80% of the time with your answer, we're going to really be at odds with the time. So please try to truncate your answers after you've been asked a question. The next paper is also eligible for best paper. It is also out of Amsterdam, and the title is Activity Tracking Up to 90 Days After Minimally Invasive and Open Pancreatic Duodenectomy in the Multicenter International Randomized Diploma 2 trial, to be presented by Caro Bruna. Welcome.
Thank you for your introduction. My name is Caro Bruna. I'm a PhD student from Amsterdam, and I'm honored to stand here before you today and to present to you the Fitbit postoperative activity tracking outcomes of the Diploma 2 trial. Like Nina already told you, we received funding from Intuitive Surgical. So minimally invasive pancreatic duodenectomy has been implemented over several years now in order to decrease surgical trauma and reduce blood loss and to improve postoperative recovery. But how do we define postoperative recovery and how do we measure it? It's usually measured during hospital admission, like the duration of hospital stay, which is highly influenced also by the hospital's guidelines, by the hospital's cultural background, but also by the preference of the physician, of course. But it's also measured by time to functional recovery, which is a slightly more objective approach, consisting of these 5 criteria. But what happens after discharge? We actually don't know that yet. In the Diploma 2 trial, I'll be very quick about this, of course, we compared minimally invasive pancreatic duodenectomy with open pancreatic duodenectomy for patients with upfront resectable neoplasm in the pancreatic head or periampullary region. The primary outcome was overall complications, and it was powered for non-inferiority. And the most relevant secondary outcome was the time to functional recovery, which was powered to determine the superiority of the minimally invasive approach. And we gave all patients a Fitbit for 3 months to measure postoperative mobilization. That was the Fitbit Inspire 2, which you can see here on the slide. We gave the Fitbit to the patient 2 weeks prior to surgery until 90 days after, and it registered physical activity, heart rate variability, energy expenditure, and sleep. Should be said that it was not worn during the surgery, during ICU admissions, or during battery charging, which has to happen once a week. All notifications were turned off, so everybody who also has a thing like this knows that it keeps pushing you to move. That was turned off. There were 288 patients included in the Diploma 2 trial, of which 250 actually received a Fitbit. The other patients either did not want a Fitbit or did not have a smartphone because you need to have the Fitbit application on your smartphone. 236 patients had sufficient Fitbit activity after surgery to be included in this analysis. And it was 155 patients in the minimally invasive group and 81 patients in the open group. These are the baseline characteristics for the cohort in which we did a Fitbit analysis. When looking at these numbers, should be kept in mind that there was a 2-to-1 randomization. So you should look at the percentages and not really at the numbers. But these were all comparable between the 2 groups. So we'll start with the daily step count. On the y-axis, you see the daily step count, and on the x-axis, you see the time after surgery. These are the outcomes for the open group, and these are the outcomes for the minimally invasive group. On the right, you see a figure which represents the difference in daily steps. Above 0 is in favor of MIPD, and below 0 is in favor of OPD. And you see here that at 30 days after surgery, patients after minimally invasive surgery walked 660 steps more, which was a significant difference. And then the difference disappeared again at 90 days. And we found a statistically significant difference in favor of minimally invasive between day 17 and day 40. Now the daily active minutes. Once again, on the y-axis, the daily active minutes, on the x-axis, the time after surgery. You see the outcomes for both groups. And once again, above 0 is in favor of minimally invasive. You see that patients were active 22 more minutes after minimally invasive on day 30 after surgery. And that difference once again disappeared at day 90. We found a significant difference between day 14 and day 37. The heart rate variability was also measured by the Fitbit. That is actually a measure on the activity of the autonomous nervous system. So to put it simply, a higher heart rate variability is a less physiological stress for the body. Here's the outcome for the 2 groups. You can see it the best on the graph on the right. You see that at day 30 and day 90, there was a higher heart rate variability in the minimally invasive group, indicating that they had less physiological stress. And it also measured the sleep, and the sleep was for the whole 90 days, not statistically significant in either one of the groups. So in conclusion, minimally invasive pancreatiduodenectomy in high volume centers in those selected patients, which we were just talking about, undergoing pancreatiduodenectomy for resectable pancreatic and periampullary neoplasms resulted after discharge as measured by the Fitbit in more daily steps between day 17 and day 40, more daily activity between day 14 and 37, and a higher HRV indicating less physiological stress. From day 22 to 45 and day 69 onwards, without differences in hours of sleep. Thank you for your attention. I will be happy to answer some questions.
This excellent paper is open for discussion. The first thought I have, since we're constantly looking for industry support for our meeting, that maybe we should remember to approach the Fitbit company to see if they want to make an investment in our meetings, since we seem to be advocating for its use. And it's a very creative idea of using Fitbit, and it's applicable to many other surgeries besides pancreatic. So that's great. I was wondering, with your data, did you throw in anything about quality of life and return to normal activity pre-op? With all your Fitbit data, do you have data just with what's conventionally used as signs that someone has recovered?
We did look at the time to fully recovery, but we did see, and I can go back, I think, like to take the daily steps, you see that he recovered quite late, and that the difference was mainly between, well, day 15 and day 40 approximately, but they hadn't recovered that yet. So we did look at the difference.
Very creative. Dr. Kendrick has a quick question.
Actually, mine was pretty much along the lines of Dr. Nealon. I think that the question for me is the steps. The first question I have is, were they just getting up to go to the bathroom more often than the ones that had it open, or was there other reasons? Now, the variability data is good because that shows health, but I would encourage you also, as he mentioned, to maybe put some quality of life assessment, return to work, something else to make sure that this data correlates with that. But great paper. I think this is a great way to back up some of those other things. People may go to work earlier, but they may not be very healthy, and your data helps us establish that. So
thank you.
Dr. Zaromsky?
Very interesting data. I was wondering if you standardized or controlled for people who had complications or no complications.
No, we did not do yet, because in the Diploma 2 trial, we saw that the complication rate was similar in both groups. So that's why we did not look at the subgroup.
Can you help me explain or understand a little bit more clearly, how does heart rate variability translate to a healthier person? If somebody is sick, if they have a fistula, if they have an infection or something like that, and you try to get them up in a chair, the heart rate goes from 80 to 120 much more quickly than if the very fit Dr. Kendrick stands up from his monitoring position where his heart rate stays very similar.
It is a bit more, so the heart rate is more subject to changes than the heart rate variability. So that's more like a stable measure, also because it's measured in deep sleep. So that's why it's a little bit more objective than just the heart rate. And it is actually the difference in the difference in time between successive heart rates, which is to do with vagal activity. And you do see it, it is very subject to changes. If people have a cold, it's already different. But because we randomized, it is, you think that it is similar between the groups, so that you could still look at the differences. But it should be kept in mind that it is measured with a Fitbit, which is not an EKG like we usually measure heart rate variability.
Dr. Clark, try to shorten your answers, please.
Just a quick comment. I've done a lot of work with mobility measuring devices, and it's great to see that Europeans aren't walking as much as I thought they would in general, with not many over 5,000. Did you see any change in the first couple of days between the two groups? Because some of our data looks at first mobility event and ambulation early on in the hospital, and you can predict adverse outcomes
based on whether or not they're getting out of bed or they're mobilizing early in that first day or first couple of days? Did you see any changes or differences?
No, we did not see that yet, but I think that's also because it was not worn during surgery. So we did see, at least in our hospital, that some patients got a Fitbit on again only after 4 days. So it's not really sure if we really wanted to look at 90 days, so really after hospital discharge.
Dr. Fleming?
I think it's interesting that the curves overlap for the first 9 days, which is basically the time that they're in the hospital together.
Yeah.
For both of these, and then it's flat, and then the
Yeah.
trajectory of
Yeah.
increase is parallels one another after that. It's flat for a week. Did you measure morphine equivalents, and are the people using more narcotics? I think it would be very interesting to see if the people who are more sluggish in their recovery are using more narcotics when they get home out of the hospital.
Yeah. No, we did not measure that, but it should be said that, of course, we had a blinding for the first 5 days. So what we did notice in patients is that, so they were walking around first 5 days, really thinking, okay, it's going well, let's walk around much. And then the large bandage came off and they saw that they had the open approach, so the massive scar. And they were like, okay, let's take things slow. So I think that's also a bit what you see. Of course, that also reflects real life practice. So I think.
Very good. Great paper. Thanks.
Thank you.
All right, our next paper is going to be presented by Nicolo Napoli, external validation of the ISGPS complexity grading system for minimally invasive pancreatoduodenectomy, insights from the IGON-MIPS registry.
Thank you.
Go ahead, thanks.
Thank you for the opportunity to be here. I'm glad to be here presenting our external validation of the ISGPS complexity grading system for minimally invasive pancreatic duodenectomy. This difficulty grading system has been recently introduced by ISGPS, aimed at improving patient selection for minimally invasive robotic pancreatic duodenectomy by matching procedural complexity with surgeon and center expertise. The procedural complexity has assessed by 5 different factors: main pancreatic duct diameter and common bile duct diameter as anatomical factors, BMI, and past history of complicated abdominal surgery or disease as conditional factors, and vascular contact as tumor factors. The presence of or the absence of this factor has allowed us to classify all patients into 3 different levels of complexity: grade A, B. It doesn't work. B and C. It's important to note that vascular contact increase the complexity of the procedure to the highest level. Regarding the competency, ISGPS has proposed 2 different measures: the central annual volume and the surgeon minimally invasive pancreatic duodenectomy experience. And it is important to note that the lowest score between these 2 factor counts to grade the competency. And as for the complexity, 3 different levels of competency has been assessed: A, B, and C, as you can see. ISGPS proposed a method for selecting patients for minimally invasive pancreatic duodenectomy by matching the complexity of the procedure with the competency of the center, as you can see. And our aim was to validate this selecting system by using the data from the Italian National Registry of Minimally Invasive Pancreatic Surgery, that has available since 2019, and at the end of 2024, counting more than 3,000 minimally invasive pancreatic surgery procedure. And the first outcome for us was severe postoperative complication. And the idea was that in complexity case A, the severe postoperative complication rate should be similar between the different level of competence. While for complexity B cases, the severe postoperative complication rate should be higher for competency A center respect to B and C center. And finally, for complexity C, the center graded with C level should outperform the other two center. So we evaluated 426 patients. And the first thing that stands out is that the majority cases are graded with complexity C in our registry, but only a few of them are operated by center C in our as a competency in our registry, as you can see here. And there is a disproportion between the rate of complexity A and C cases operated in especially in grade A competency center, as you can see here. In the competency A center, there is a high proportion of complexity C cases respect than in grade C competency center, and this reflects a better selection in competency C center for sure. First of all, we validated the complexity grading system by highlighting the increase in the severe postoperative complication rate from complexity A to complexity C cases, as you can hear. And the same figure has valid for considering cases only after the completion of the learning curve, as you can see here. Not only postoperative complication increase over time, but also clinical relevant post-pancreatic fistula, grade C post-pancreatic fistula, and drained fluid collection, as you can see here. Regarding the IS-GPS complexity parameters, all the parameters increase from grade complexity A to complexity C, except for previous complex upper abdominal surgery. But even if in our registry, the only parameter that is independently associated with the developing of severe postoperative complication was the small main pancreatic duct, as you can see here. Then secondary, we observe that severe postoperative complication rate increase from competency A to competency C center in order to validate the competency grading system. But not only the postoperative complication, but also the fistula, biliary leak, post-pancreatectomy hemorrhagia, and reoperation rate, as you can see here. This probably is associated with a better selection for competency C center. As you can see here, they select patients with a small, with a bigger main pancreatic duct and a bigger common bile duct, respect in competency A center. And the only parameter that increases from competency A to competency C is the tumor vascular contact. Regarding the validation, in complexity A cases, the severe postoperative complication rate in our registry was similar between the different levels of competency. And it's important to note that 90-day mortality, grade C, pancreatic fistula, and biliary leak were null for complexity A in all the three competency level, as you can see here. For complexity B, the severe postoperative complication rate was higher in center with competency A, respect competency B and C. And this reflects an increase in the result for conversion rate, blood loss, and 90-day mortality, as you can see here, from A to B and C. And in the last, the complexity C cases, competency C center outperformed the other two competency level regarding not only severe postpartum complication, as you can see here, but also regarding the clinical relevant pancreatic fistula, post-pancreatectomy hemorrhagia, and also postoperative uneventful course, as you can see here. It's important to note that the competency was strongly associated with the deviation from the preoperative planned procedure, especially with a shift towards to total pancreatectomy, as you can see in this chart. So in conclusion, ISGPS recently introduced a complexity grading system for minimally invasive pancreatic duodenectomy, using a well-established literature. This study validates the ability of this score to predict minimally invasive pancreatic duodenectomy outcomes. And it highlights the importance to matching the surgeon and center ability with the complexity of the procedure in order for promoting a safe adoption of minimally invasive pancreatic duodenectomy, but also in order to enhance comparison between center and technique. Thank you.
Questions from the audience? Questions from the audience?
Maybe I'll briefly just mention that I have no optimism that America will ever be able to regionalize anything. But it seems like these data would help everybody if we were going to try to do it in a logical, rational way to say maybe these operations need to be done in a specialized center.
Yeah, I agree. Dr. Romer brought up the point of the number of pancreatic duodenectomies done by an individual surgeon versus an institution. And I think that's really important because even the definitions of high volume, I think, are quite skewed based on whoever publishes the study as opposed to reality of what's necessary.
It's not only the volume for the center, but also the expertise of the surgeon. And it's important to note that it's not considered the expertise of the surgeon that performed the procedure, but the expertise of the most expertise surgeon presence into the procedure, even if is the assistant one.
Yes, great.
Very well
Thank
presented.
you.
Thank you.
Okay, our next paper comes from our friends from Korea. And the title of the paper is Laparoscopic versus Open Pancreatic Duodenectomy for Periampullary Tumors, a randomized clinical trial, to be presented by Dr. Yoon. Welcome.
Thank you, Chairman. Good morning, everybody. It is my honor to be here to present our result of our RCT, compared laparoscopy versus open PD. This one. No disclosure. This study was published in International Journal of Surgery last year. Since the first report by Ganier, minimally invasive PD was rarely performed before 2000. Thereafter, encouraging outcomes by pioneering surgeons like Kendrick here has led to growing adoption of this procedure. First RCT was published in 2017. Before the first RCT, cumulative evidence of MIPD was based on retrospective studies by experts. The evidence indicate that laparoscopy PD was associated with longer option time, but less blood loss, shorter hospital stay. Post-operative complication oncology outcomes were similar between two procedures. However, concerns regarding safety laparoscopy PD persisted even 20 years after the initial reports. In earlier days, Ganier concluded laparoscopy procedure offered no benefit. 20 years later, Leopard 2 study raised unexpected and worrisome safety concerns. Today, the RCT comparing laparoscopic and versus PD have shown mixed result. These inconsistency were likely it is influenced by various learning curve of participant sessions. Different outcomes have been reported in terms of hospital stay, open conversion, blood loss, post-op complication, and mortality. Current evidence from RCT have some limitation. Advantage of laparoscopy shown in most RCT is shorter hospital stay without compromising perioperative outcomes. However, hospital stay is subjective endpoint rather than objective recovery. Leopard 2 study used functional recovery as the primary endpoint, but the trial was prematurely terminated, limiting its conclusion. There have been no RCT demonstrating clear benefit of pure laparoscopy in terms of functional recovery. In this viewpoint, this study aimed to compare functional recovery as primary endpoint between two procedures with postoperative shorter oncology outcomes. This RCT included the patient from 7 tertiary centers. Patient and surgeons were not blinded. The randomization was performed in a 1-to-1 ratio with block size of 6. Patients were stratified by preoperative risk of POPF, including BMI and PDOC size. The first procedure was performed in pure laparoscopic method. For pancreatic reconstruction, 2-layer ductal mucosa PJ was performed. Participant surgeon included first-generation surgeon with experience of more than 150 laparoscopic cases, and second-generation surgeon with experience of 20 to 100 laparoscopic cases. This slide shows learning curves of participant surgeon. First-generation surgeon had long operation time, requiring 40 to 60 cases to achieve technical proficiency. In comparison, second-generation surgeon trained by first-generation surgeons, they had this significantly reduced is learning curve. Primary outcome was time to functional recovery, containing the 5 domains. The definition is the first day when all 5 domains are achieved for 3 consecutive days. The 5 domains includes adequate pain control, restored mobility, adequate diet intake, and no need for fluid collection, absence of infectious sign. Secondary outcomes include perioperative outcomes, oncology outcomes, and cytokine level. The participants included patients with perioperative tumor without evidence of major vessel invasion and metastasis. We excluded high BMI, neoadjuvant therapy, and malignancy in other organs. Sample size calculation based on the length of hospital stay due to limited functional recovery data at the time of trial design. Hypothesis was laparoscopy will be 20% faster than open PD. The calculated sample size was 126 in each group. This slide shows patient flow chart. The more than 800 patients were evaluated for eligibility, and 252 patients were enrolled, and excluding patient withdrawal and unexpected metastasis during operation, the 235 patient underwent is allocated a surgical procedure. This patient included modified intention treat analysis. After excluding open conversion, 229 patients were included per protocol analysis. Here, baseline characteristics, there's no difference between 2 groups in terms of age, performance status, comorbidity, and risk of POPF risk. and indication of surgery and say 99 level. Here is primary and secondary outcomes. The mean time to functional recovery was 1.3 days shorter in laparoscopic group compared with open group. And laparoscopic group achieved 100% rate of functional recovery, better than open surgery. As a secondary outcomes, operation time was longer in laparoscopic group, but there's no these other secondary outcome difference in terms of the blood loss, hospital stay, and arterial resection, number of lymph node, and complication, and readmission. But there's no this mortality between two groups in both the groups. This figure shows cumulative is achievement of functional recovery after surgery. The group they showed this was faster than open group. Among 5 domains of functional recovery, restored mobility was most significant. We performed sensitive analysis regarding time to functional recovery according to age and complication indication. The improved recovery is significant in patient with more than 65 years of age and with complication, and it's a non-malignant disease. We compared survivor in 126 malignant disease patients. There was no difference overall and recurrence-free survivor. We checked this cytokine level on posterior 1 and 3, 7 day. There's no difference of BMI adjusted cytokine levels between two groups. In summary, primary outcomes were significantly better in laparoscopic group. Among 5 domains, restored mobility was most significant. The benefits improve functional outcomes were more pronounced in patients with old age and post-operative complication and non-malignant diseases. Post-op outcomes and oncology outcomes were similar between the two groups. There was no mortality in both the groups. There was no significant differences in magnitude of cytokine elevation between the two groups. This study has several limitations. Actual reduction of 1.23 days in functional recovery time was less than anticipated 20% in sample size calculation. It is partly due to utilization of the hospital stay caused by limited function recovery data at trial design. It raises uncertainty regarding its clinical significance. We exclude high-risk patient. Patient and surgeons were not blinded. Advanced laparoscopic PD with highly experienced surgeons may not extend to surgeons in volume center. Other limitation is a heterogeneous cancer type with a small subgroup size and short follow-up duration. In conclusion, laparoscopic PD demonstrated modest reduction in the time to functional recovery compared to open surgery in selected patients treated by experienced surgeon. However, its overall clinical benefit remains uncertain due to study limitation and similar outcomes in other outcome parameters. Future studies are necessary to clarify its advantage and to identify the patient population that may benefit most. This study is performed by the members of KMIPS. I'd like appreciate their contribution to this study. Thank you for your kind attention.
This beautiful study is open for discussion. I'm wondering if you could look to the future and tell us, now that we have so much robotic surgery in this same space, what would you say worldwide is going to be the uses of laparoscopic surgery now that robotic surgery has emerged?
Yeah. Actually, it is now surgeon doing a lot of robot surgery, but this laparoscopic surgery it requires a long learning curve. As you can see here, the advantage of laparoscopic surgery is small. But I think that is we are living in transition time to robot surgery. So before that, we need to have the skill for laparoscopy robotic surgery because robotic surgery is available only a few these centers. If a surgeon want to give this minimal invasive surgery to patient, there is if you don't have robot, that means there's no option for MIS for patient. So that's why I think this we need both the skill for laparoscopy and robotic surgery, and this training also important. We have the long learning curve, but the second generation, if they receive designed program, their learning curve will decrease. I think this future is all the MIS replaced by robot surgery, but at this time, we are transition time. We should have the both laparoscopy and robotic skill.
Chris?
Yeah, we have actually, I would argue, the best two laparoscopic pancreas surgeons on the stage right now. Michael, what's your answer to that question? So we heard from Yusak as far as, in the age of, obviously the robotic approach is spreading more rapidly. I mean, watching you operate and watching use it, I mean, you guys are outliers in terms of what is achievable laparoscopically. So your thoughts on the same question?
Thank you. And I agree. I'll just tell you my bias, right? I think robotic surgery helps surgeons that cannot do this laparoscopic.
Yeah.
If you can do it laparoscopic, there is no advantage to the robot. I know the studies, I know the randomized trials, and I would argue most of those trials are by surgeons that are, and I'm not knocking any of them, but they are not as proficient laparoscopic.
Yeah.
And then they either did a bunch of laparoscopic surgery and then they moved to robotics and then they compare the outcomes. Well, they've already got their experience on the lap group. With all that said, I think it doesn't matter if it's laparoscopic or robotic. I think the outcomes should be expected to be the same, especially by those with experience. If they're not, that's a problem. But I would say that the future is all robotics because it is easier to learn. It's easier for me to train someone laparoscopic than it is for me to train somebody laparoscopic. Train robotic is easier. And I think eventually we'll actually have real things to talk about on the stage where robotics adds something other than a more comfortable console with, power windows and a comfortable heated seat. Yeah.
As Yusak pointed out, I mean, that's going to, it's actually in resource limited areas too, the availability of the robot's going to make a difference. And so I think it's absolutely important that we have people like you who can do it.
No offense to anybody that's in love with Intuitive, but if we had more competition and the price of robotics could come down, I think robotics would have flourished even more because it is a cost issue and the time and the learning curve, even in our hospital. I mean, robotic hernia repairs have now become 3 times longer because we're doing them robotic. And you have to at some point ask the question, are we doing the right thing yet? So.
Anyhow, so real quick question. So superb study and nicely presented. I congratulate you on a really well done study. You're statistically powered for time to functional recovery. In your long-term survival data, there was no statistical difference. Now we don't know obviously if there truly is going to be because we're not powered for that. But a surrogate, we know that more people, the receipt of adjuvant therapy usually correlates to long-term survival. I was wondering, and I didn't see that you presented, was there a difference in receipt of adjuvant therapy in the MIS group versus your open?
Actually, this patient with malignancy very heterogeneous. Only the 50% patient had is pancreatic cancer. Actually, no difference is timing of adjuvant therapy, the rate of adjuvant therapy. There's no difference. But this data is very short. This follow-up period. We need to more studies with longer follow-up. And the focus is only on pancreatic cancer.
This is an outstanding paper. They're really, really great. Jin, do you have a comment?
Yeah, a couple comments. I just want to congratulate Yusak for this wonderful work. this should be considered the gold standard for laparoscopic Whipple. I think in places with limited resources, with no robot, this is the best minimally invasive data, 0% mortality, showing, functional benefit. On the other side, there are a couple of things, I agree with Dr. Kendrick comment, there are a couple of things that you cannot do with laparoscopic compared to robotic Whipple. First of all, you cannot do telesurgery, remote surgery. In countries, remote surgery is getting popularity that you cannot do this. Second is, again, the learning curve is definitely shorter for the robotic approach. And you truly only need one surgeon to do robotic surgery. You need a team to do laparoscopic Whipple. So it will be easy for me to travel to the other part of the world to do robotic Whipple, but you may have to bring your own team to other part of the world to do the laparoscopic Whipple. That's just my personal bias, but wonderful work.
Okay. And actually, now many Korean surgeons doing this robot. They are shifting the MIS method from laparoscopic to robot. But is mostly do this hybrid laparoscopic resection followed by the robotic anesthesis. But I understand your this point. But at this time, I think we should have both the skills for laparoscopic and robot. And once it is surgeon have the ability of laparoscopic surgery, they can easily switch this open method to robot surgery.
Our colleague from the Netherlands, do you have a question?
Yeah, I'll be very short. Thank you for your presentation. Great work. And I'll make sure that we include your study in the overview of the RCTs in the upcoming presentations. I have a question regarding your sub-analysis, because I was quite surprised that you found a larger benefit in terms of functional recovery in the group of patients with complications. If we look at our data, not only from Diploma 2, but also the national data, we found a larger benefit in patients that did not have any complications. And we see that these patients even have a shorter time to functional recovery. Have you looked into it, and can you explain this finding?
Finding is
that there was a larger benefit in terms of time to functional recovery in the patients with complications.
Yes. This our data show this the better recovery in patient who experience post-op complication. I don't know the exact reason, but I think that is another advantage of laparoscopic surgery. Laparoscopic surgery can more likely rescue the patient who experienced severe complication. But I don't know the exact reason. Yeah.
All right. Thank you.
Thank you.
Very nice. I just want to mention that this group and our friends in the paper after the next paper, one coming from Korea and one coming from China. We just want to say at the Pancreas Club that we're very grateful for the amount of effort you put into us to join our meeting.
Agree. This next paper is also eligible for the best paper. This is going to be presented by Julia Menso, Delayed Gastric Emptying After Robotic-Assisted Pancreatoduodenectomy, Analysis of the Transatlantic Robotic Pancreatic Consortium.
Yes, thank you, Dr. Kendrick, for the introduction, and we're happy to share the results of the TROPAN Consortium. So we received funding from, received a private donation and funding from Intuitive Foundation and the Dutch Cancer Society for the ongoing Diploma 2x2 trial. So robot-assisted pancreatoduodenectomy is increasingly performed internationally, including various training programs and well-standardized techniques and postoperative outcome definitions. But despite these standardizations, we still see large absolute differences between 10 to 30% in postoperative complications after robotic Whipple. Mainly, for example, the 500 robotic Whipple series in Pittsburgh, but also the Dutch pancreatic cancer audit data. We were wondering what causes these international differences and how can we learn from each other and improve our outcome. So therefore, we set up the Transatlantic Robot Pancreas Consortium, TROPANC, to elucidate the etiology of these international differences in RPD outcome. And we included expert centers with an experience of over 150 robotic Whipples. And we looked at differences in patient selection, intraoperative technique details, learning curve, and postoperative management to find how can we improve our outcome. And we started with the first project focusing on DGE, for which we conducted a binational multicenter study, including 7 centers from 2 countries. And we included all consecutive RPD patients between 2008 and 2023. We focused primarily on DGE grade BC according to the ISGPS definition. And the secondary outcome was primary DGE, so DGE without concomitant abdominal complications. We used the prospectively maintained databases of all participating institutions, and we also collected additional data regarding intraoperative technique and postoperative measurements via a surgeon survey. We performed a multivariable analysis to identify predictors for both DGE and primary DGE, and we performed a sensitivity analysis excluding patients with PDAC and pancreatitis, and also a sensitivity analysis excluding the mastery learning curve. So the first 84 procedures per center. So the baseline characteristics showed that we included 1,842 patients in total. The median age was 68 years old. Just over half was male. The BMI was 26. About 16% of patients had preoperative pancreatitis and 26 diabetes. And the neoadjuvant therapy in patients with PDAC was around 49%. And interestingly, PDAC pancreatitis was 41% in total, whereas in the US it was 46% and in the Netherlands only 25%. Then for the intraoperative outcomes, the median operative time was about 390 minutes. We found that half of the patients had a soft pancreas, and the majority of pancreaticojejunostomies were performed according to the Bloomgart method. 1/3 of the gastrojejunostomies were stapled, the other ones were all sutured, and the pylorus preservation took place in 10% of patients in only 1 center. And abdominal drains were placed in the majority of the patients, as only 1 center stopped drain use from 2020 onwards. So when we look at the postoperative outcomes, DGE was 15%, with only 6% of patients who had primary DGE. The major complications occurred in 1/3 of the patients, with fistula 15%, bleeding 7%, and bowel leak 4%. The 30-day mortality was 1%, and the length of hospital stay was about 8 days. So if we looked at stapled GJ and sutured GJ, we found that stapled DJ had significantly less DGE and primary DGE compared to patients who received sutured GJ. So then we investigated the predictors for DGE first. And here you see on the y-axis, you see potential predictors, and on the x-axis, its predictive value. And we found that age, as well as sutured GJ, drain use, pancreatic duct size, and intraoperative blood loss were associated with, were predicted for DGE, and also the postoperative complications as we expected. Then we looked at the specific association of GJ technique on DGE grade BC, and we found that sutured GJ was associated with a 10% higher risk of DGE grade BC as compared to stapled. Then we did a similar analysis for the primary DGE, and we found that here also sutured GJ was associated with a 3% higher risk for primary DGE as compared to stapled. So the TROPANC Consortium is actually the first international collaboration that investigates RPD outcome in expert centers. It's currently the largest RPD series that exists, and it was, as a matter of time, we didn't include all the differences between USA and the Netherlands, but we found considerable and unexplained differences between both countries. So we found, for instance, the PDAC pancreatitis rate in USA was twice as high. We did perform sensitivity analysis excluding the PDAC and pancreatitis patients, but still we found similar differences. And also for the learning curve, we saw that the series of the US expert centers were considerably larger than the Dutch centers. but also the post-mastery sensitivity analysis showed similar differences. So with the main focus on DGE, this study found that approximately 2/3 of patients with DGE were actually secondary to other abdominal complications, mainly fistula. Fistula is one of the strongest predictors for DGE, as we expected, and this supports the hypothesis that it's mainly secondary. And for the primary DGE, interestingly, we found no difference between the countries, and the predictors were age, stapled GJ, and abdominal drain use. It's important to note that for the abdominal drains, only 7% of patients did not receive an abdominal drain in only one center. And for the stapled GJ, it was only a relatively small risk difference for primary DGE, only 3%. Of course, there's some limitations. It's a retrospective study design with potential selection bias. Although we scored all complications again, when we collated the databases, we still cannot exclude inter-observer variability. And for the postoperative measurements, so although we highly standardized intraoperative techniques and postoperative outcome definitions, postoperative management was not uniform between our centers. So for example, the Porsche study in the Netherlands resulted in a very low threshold for percutaneous drainage, which likely resulted in a higher detection of complications, although the mortality in the Netherlands therewith decreased. So to conclude, DGE is mainly a secondary complication, mostly related to fistulas. And although that stapled GJ was protective for DGE and primary DGE, we think its clinical value remains questionable. So therefore, we would recommend to focus on other abdominal complications, which we're very excited to continue with the next projects of TROPANC. And finally, I'd like to thank the team of some of them are here for their great effort, and I'm looking forward to the future. Thank you.
Excellent paper, again, from the Netherlands. Thank you very much. We'll kick it right off with Dr. Bulmer.
Two things. The trade-off to the stapled is maybe a higher bleeding risk from that. Do you have data on that? And secondly, historically, DGE has been associated not only with the fistula, but higher fluid levels, intraoperative fluids. It seems like you don't have that as a variable. What's the length of time between a sutured and a stapled GJ? And is that length of time in the operating room more fluid, et cetera? Something to look into, because that has always been looked at. It's actually AFib was the most associated thing, and it's because of the higher fluid.
The second question, thank you. We will look into it for other projects because we didn't include it. And then for the bleeding, we also didn't investigate the specific complications next to the DGE, but we're looking further into DGE in future projects. So I'll note it. Thank you.
Really, really great talk, Brock Hewitt, NYU. I'm just curious, a couple small questions here for enhanced recovery. Do you guys have different pathways and things like that? We have a subset of patients that we don't even put an NG tube in, for example, after operating, just to kind of speed that up. Also touches on the intraoperative fluid management as well. We try to keep that low, generally under 2 liters for the whole case for a lot of these patients. And then a couple small technical things as far as when you're talking about stapled, I'm assuming you're talking about probably using a 60 millimeter stapler for that, and then sewing the commonotomy, I'd imagine. And then for the open, for the hand sewn anastomosis, I mean, a lot of those people in this group, have come out with paper in the back that talked about the size of the open anastomosis, right? Is it 3 centimeters, 4 centimeters, 5 centimeters? Because that does have an impact as well. So there's a lot of heterogeneity, even when you have an open or a hand sewn GJ as well. So can you comment on a couple of them?
Yes, thank you. So regarding the GJ size, we also collected that data via the surgeon survey, but we noted that most centers were using the 60 millimeter stapler, and for the suture, one center performed suture GJ, they were all 6 to 7 centimeters. So we didn't have enough variation in our cohort to include that.
Henry Pitt, Rutgers. A dozen years ago, we looked at the NISQIP data in DGE and found, as you did, that the pancreatic fistula is the only really independent driver of this outcome. In that analysis back in the day, we also looked at anticolic versus retrocolic, and it turned out that that was not as significant as the pancreatic fistula. So my first question is, did you look at anticolic versus retrocolic, or were they all done the same way? And then, you looked at drain placement, but drain management clearly plays a role in pancreatic fistulas, which play a role in DGE. So did you look at drain management as well?
Thank you, Dr. Pitt. So for the, indeed, as compared to the NESCIP series, we, the first question, please remind me what it was about. Yes, so thank you, Jen. So the majority of the centers performed retrocolic. So the same with the GJ size, we didn't have enough variation in our cohorts. And for the drain management, we didn't include it in this paper. It was quite hard to keep it comprehensible as we found so many differences in the different complications, but it's one of the, it's on the agenda for the next project.
Julia, real quick question. First of all, wonderful presentation, as always, great study. So in terms of ISGPS criteria guidelines for classification, I find that DGE is the most subjective of all of them. It is difficult. So if you and I sat down, both have relative experience and went through 10 patients, there may be a big user variability. So just to clarify, you guys evaluated all of the data de novo and classified it. So how many different observers, and did you check for inter-observer variability? Because as your mentor, Mark Besseling, demonstrated, the variability can be as high as like 50%, like flipping a coin.
Yes, thank you, Dr. Wolfgang. So both my colleague Bram van den Broek and I went to US and we graded the complications there with the research fellows. So I think in total there were, well, we graded it together. In total there were about four observers.
Did you do a little control where you both evaluated the same cases and looked at the inter-observer agreeability between the two of you?
We didn't, but that
Interesting to
would be an interesting.
I would just say another problem, which I think makes it very subjective, is placement of an NG tube equals delayed gastric emptying, regardless of any true diagnosis. And I think, one thing you might consider is looking at the incidence of delayed gastric emptying by surgeon, because some surgeons, place an NG tube quick and they start to treat them, and that's called delayed gastric emptying, whereas another may give Reglan and just kind of wait it out, and that's not delayed gastric emptying if you don't have to put an NG tube down. So there's so much vagueness in the diagnosis of delayed gastric emptying, it makes it difficult. But that was more of a comment, maybe looking at surgeon specific preferences. The last comment I would say is, even on leaks, you reported 6% had primary DGE, but how thorough was that evaluation? Was there linear fluid collections that would be consistent with a pancreatic leak around the posterior wall of the stomach that weren't big enough for a drain, so you never really called it a leak, but it was? So kind of subclinical leaks in a way.
Yeah, so we
look at that?
excluded all the pancreatic fistulas, bowel leak, and bleeding grade BC, because that was the data we have. So indeed the grade A, we don't know.
Yeah, no. Great paper. Thank you very much.
Thank
Julia,
you.
just real quickly, Julia, great paper. I think there's a difference between gastric ileus, which is a thing, versus gastroparesis, which is what we usually think is the cause. And I don't know, we danced around it, and I think it's very difficult to tell the difference. But the fact that these are the ones that were associated with complications, were they actually an ileus and not a gastroparesis? Also, were the patients with hand-sewn, were they more likely to have a fistula?
So, well, we didn't, because the hand-sewn was only performed in one center. So there will be a comparison between one center and the other. So that's quite hard, because then we couldn't correct for all the other postoperative differences. But we noticed that all US centers were way lower than the Dutch fistula rates. And for the ileus, we don't have that data, unfortunately, but yes.
Yeah.
Mhm.
Great.
Thank
Thank
you.
you.
Okay, the next paper comes to us all the way from China. This is eligible for best paper. The title of the paper is Differences in Grade C Post-Pancreatectomy Hemorrhage with or Without Clinically Relevant Pancreatic Fistula After Pancreatic Duodenectomy, a Retrospective cohort study from China to be presented by Dr. Dai, the Nanjing Medical Center.
Good morning, everyone. I'm Yuran Dai from the First Affiliated Hospital of Nanjing Medical University, Nanjing, China. And it's my great honor to be here. Today, I'll talk about the difference in grade C post-pancreatectomy hemorrhage, or PPH, with or without clinically relevant pancreatic fistula, or CRPOPF, after PD, a single-center retrospective cohort study. No disclosure. PPH is a serious complication that causes up to 38% of mortality with less than 10% of morbidity. Thus, it has always been a major concern for pancreatic surgeons. The ISGPS unified the definition and classification of PPH in 2007, which has been around for nearly 2 decades. Late PPH occurs more than 24 hours after surgery, and the severe ones, grade C PPH, is life-threatening and is our focus. Currently, most studies have attributed late PPH to CRPOPF. The idea is that the pancreatic fluid erodes the vessels. But in practice, I believe you all have the similar experience that late PPH is not always accompanied by a CRPOPF. So why does this subtype of bleeding occurs? How should we manage it? Are there any preventive measures beyond traditional fistula prevention? These questions led us to our study. From 2014 to 2023, we looked at all the PDs in our institution and focused on grade C PPH. Out of 3,793 patients, 3.5% developed late PPH, with 70% classified as grade C. 90 patients were eligible for analysis. Among them, 58% had concomitant CRPOPF, whereas 42% did not, which is a significant proportion. Here's what we found. Firstly, baseline demographics. CRPOPF group had a higher BMI, a smaller main pancreas duct, and more soft gland texture. Except for these well-known risk factors for fistula, the baseline characteristics were mostly comparable. When it came to bleeding patterns, we saw big differences. The interval from surgery to first bleeding in CRPOPF group was 13.5 days, almost twice of the 7 days of non-CRPOPF group. And the bleeding sites were also different. Specifically, in the non-CRPOPF group, the blue ones, the bleeding occurs early and concentrated. And in the CRPOPF group, the orange one, we saw 2 bleeding peaks. The later bleeding peaks was because of the fistula, and the earlier peak, similar to the non-CRPOPF group, indicates that there might be a potential common etiology. As for the bleeding sites, the gastroduodenal artery stump was the most common bleeding sites in the CRPOPF group, which is understandable because it's easily in full contact with pancreatic fluid. But in contrast, the hepatic artery and other bleeding sites in the surgical area were more prevalent in the non-CRPOPF group. The left figure indicates that there might be a potential common etiology, and the right figure indicates that the bleeding caused by the common etiology concentrated in the preserved areas, which needs thorough skeletonization of visceral vessels. So we speculate that this potential common etiology might be related to the thermal damage from energy-based devices. Now the outcomes. The CRPOPF group had a mortality rate of 38.5%, almost 3 times higher than the 10.5% in the non-CRPOPF group. And the in-hospital stay, ICU stay, the costs were more higher in the CRPOPF group. So to sum up, the CRPOPF could be a novel classification criterion for grade C PPH. in terms of etiology, bleeding patterns, outcomes, and treatment burdens. And the etiology and preventions for late PPH without POPF warrants attention and future research. Finally, I'd like to acknowledge the efforts of the entire team, especially my advisor, Dr. Jishu Wei. Thank you all for listening.
Dr. Kendrick has a question.
Thank you for this. Thank you for this excellent paper. My question is, it's intriguing that you would go to the conclusion of a thermal injury as opposed to many other things that could be delayed. Were any of these procedures done minimally invasive where you were able to go back and view a video and have suspicion of thermal injury? Or where did you come up with the idea that these are potentially thermal injury versus 10 other mechanisms?
Thank you, Professor. It is indeed just a speculation without valid, solid evidence. You can come up with your own thoughts. The aim of our study was to draw attention to this overlooked potential common etiology that's beyond the fistula.
You did a great job of that. I think it's a great paper. Were any of them done minimally invasive where you could go back and look and see if there was evidence of some kind of an injury or a tie or a clip that was not positioned well?
We can't go back to see how the.
You don't have video?
Yes.
Okay.
Chris?
Yeah, so I agree with Dr. Kendrick. Just, yeah, superb presentation and a very important study. And I think that some centers are seeing, like, I think it's on the rise, is delayed hemorrhage. And one of the things that we're seeing is that in the cases in which there's arterial reconstructions done, that the rate is somewhat higher. I saw that your center does a lot of arterial work, and I saw that you had some vascular parameters. I didn't catch it. So that vascular arterial resection and reconstruction was not an independent risk factor for the non-pancreas fistula related pseudoaneurysms, just to be clear. And the second thing is, in your patient population, is radiation used preoperatively? And in patients who had arterial resection reconstruction, was radiation looked at as a potential risk factor?
Institution radiation was always after the surgery.
Always after, okay. So, and how about when you did your multivariate analysis, arterial resection and reconstruction was not an independent risk factor for the non-fistula type pseudoaneurysm?
Yes, it's not a.
It's not,
factor.
okay.
Next.
Dr. Dai, thank you so much for a great presentation. I want to ask you a question that Dr. Kendrick actually asked about the MIS use and the bleed as well. And I thought you were getting somewhere with the thermal energy use as well. So at AHPBA earlier this year, Melissa Hoch's group actually presented that comparing robotic Whipples to open Whipples, their fistula rates are actually lower. But when the fistula happened, major hemorrhage was actually more common in the MIS group. And I remember having this conversation with Dr. Vollmer as to why that may be. And we thought that in an open Whipple, the way you find your SMA is that your left hand feels with the SMA and you're riding on top of it and you're not as close as you think you are. But in an MIS fashion, whether laparoscopic or robotic, the way you find your SMA is that you find either the adventitia or you see it pulsating. And because you're that much more magnified, you're often closer to the SMA than you think you are. And you're burning up and you're riding that plane with your vesicular or a harmonic. And that's where thermal injury could come in, because you're that close and using an energy device. And congruent with their data as well, they see that the bleeds in the MIS group is not from the GDA, they're from the SMA pseudoaneurysms. So I guess based on your data, in the absence of video, do you have data to look at the MIS group and whether the bleeds were SMA pseudoaneurysms and not GDA pseudoaneurysms? Sorry, that was a long question.
Could you just repeat the?
Do you have a minimally invasive? Do you have a minimally invasive cohort that you could look at the video? You do not, is that correct?
We didn't take videos for all the surgeries, so there are just a few peaked surgeries.
But you have data on the site of the bleeding based on MIS. Yeah. Was it SMA or were they GDA?
Yeah, he's saying you have the site of bleeding and you have some patients with MIS with video, could you go back and look at that?
Maybe you can't find the videos.
Okay,
Thank you.
thank you.
Very nice paper. One question I have is, you may know, for over many years, there's been a question of high volume surgeon, high volume center, and the differences in outcome. And for the first phase, meaning just the first try of an operation, there is a separation, but it's not vast. But then the next nuance of those studies was to look at rescue. And by rescue, we mean someone who has to have a second operation after a Whipple. And in that, the separation in mortalities was wide. And the patient and those low volume centers and low volume surgeons had a mortality in the 30 or 40%, whereas those in a higher volume had a much better outcome after rescue. With your mortalities, do you know how many of those patients actually did have a second operation, or did they die without having even had a second operation?
We didn't collect the data of second operation.
Thank you very much. It's been
you.
great.
Okay, our final paper is a short oral by Victor Purim. Will present this from University of Alabama at Birmingham. This is enhanced recovery pathways for pancreatoduodenectomy may not provide similar benefits to other operations.
Thank you all for having me. It's a pleasure to be here for the first time. Good morning, everyone. And I'm going to discuss our experience at University of Alabama with ERP following Whipples. Where's the click? So as we all know, ERS protocols, or as now we call it, enhanced recovery pathways, have been in place for a multitude of different surgical subspecialty, providing a multitude of different benefits. But we beg the question, what's the benefit for the pancreatoduodenectomies? And this has been studied before and has been shown to decrease the time to both liquid and solid intake, first bowel movement, removal of NGT, but most importantly, reducing morbidity, delayed gastric emptying, length of stay, and notably with comparable readmission rates. However, we wanted to look at our experience with ERP in our very particular surgical population. So to achieve this, we used our ACS NSQIP data set from an institutional setting in the tertiary center in the deep south of the United States, important to know. We selected patients greater than 18 years old with PDAC with undergoing Whipples from 13 to 23. The ERP protocol was established in 18, so we divided the cohort in pre-ERP and post-ERP. It excluded the 2018 period as a transition period of implementing the protocol. So we had 458 patients with 280 on the pre-ERP protocol and close to 180 in the post-ERP era. Comparing the both cohorts, in the ERP period, we had more Black patients, patients with ASA classifications 3 and 4, more patients with heart failure, as well as, maybe most importantly of all, malignant neoplasms and those receiving neoadjuvant chemotherapy, which was not a thing in the pre-ERP era. What we found postoperatively, shorter length of stay, like we saw on the literature before. However, that came at the cost of higher readmissions and postoperative complications. So we were worried about this, and this is what we suspected on our subjective experience. So we investigated that further. What's driving the decreased length of stay? In fact, ERP status is contributing positively on decreasing the length of stay or the stay in the hospital for these patients. Besides that, having a diagnosis that it's not a malignant neoplasm is doing the opposite effect. So keeping the patients longer is probably because of the gland consistency, as well as having a complication is keeping them longer in the hospital. But what about the complications? What may be the trade-off for having ERP implemented? Well, we saw the ERP itself is not associated with the complications. However, comorbidities such as severe COPD, or having lower BMIs, meaning a more malnourished patients, as well as having a reoperation might be driving the complication and giving us this trade-off in this population, the post-ERP era. So this is very preliminary data, but we hypothesize that the implementation of ERP may be associated with decreased length of stay at the cost of 30-day readmission and postoperative complications. However, importantly to know, we're still categorizing specific complications to see what's driving these higher numbers, as well as accounting for the total length of stay in terms of accounting for the period they come to the hospital in the readmission setting, as well as ERP adherence, which is probably the main thing everyone is looking for in a paper involving postoperative ERP protocols. Happy to take any questions.
Thank you for this excellent paper. I have a quick question. Did you have a number of total days of hospitalization? Did you look at that? I didn't.
We're actually looking at this right now. We're almost done with collecting the data. Our hypothesis is that's going to be pretty similar at the end when we account for the total length of stay, when we account for the readmissions.
They may be the same. I guess the concern was that the total number of days may be higher in those that left the hospital early because you showed the complication rate. And so my question for you is, what would you recommend if someone leaves on one of these early recovery protocols early? Do you do anything different with the follow-up? Do you have them come back? Do they get a phone call by a nurse in 48 hours? How do we salvage these patients so that we don't get to higher grade complications?
I think that's a great question. It probably was one of the main drivers to start looking at this because we saw patients that sometimes would go home and in our situation in Alabama, sometimes they go very far away from our centers. So we lose contact a little bit. As well, I think the ERP would have a suspicion this might be, it's going to be in the full analysis. We run these patients a little drier because of the protocol, giving them less fluids. Right. So I think that might be driving, for example, the higher rates of AKI. So, and I think postoperatively, we can think of maybe the next step, thinking of implementing like a follow-up period in a short period of time. I think that's a good idea.
Well, that's great. Thank you. Go ahead.
Thank you so much. Lisa Baum from the University of Lübeck in Germany. Really important study, and I think that's something we always underestimate how important these things are. I mean, did you take a look at how these patients went into surgery? Because I mean, pancreatic cancer patients have sarcopenia, they are often frail, and all of these things really determine first what kind of complications do they have, how severe are they, how severe do they impact them long term. Plus the other thing is how much can they actually benefit from ERAs. And I mean, that's something we see right now in Europe. We have this big prehabilitation movement. We're doing one of these prospective trials, quite a few others are too, that we really try to kind of get ERAs and all of these aspects into the preoperative course in order to make them fit to survive complications.
I think that's a great question, especially coming from someone from Europe, because obviously the patient population is going to be very different. And alongside this project, we're actually doing a project of looking at the nutritional aspect of these patients. You know, we just presented at HPBA at weight loss after Whipple's. And we have a poster after that about this. We'll be happy to take a look. But definitely, I think maybe this can help us select better the patients for doing ERP, or maybe adapting a little bit, especially the more frail patients. And I think this is probably going to help explain why ERP is not working in Alabama. I think this is the patients who are actually more frail, more needing a different kind of approach for the postoperative period, for sure.
Thank you so much.
Thank you. Last question, Dr. Evans.
Yeah, nice presentation. I'm from I'm working right now in the deep Midwest, which may not be too different from the deep South, but you know, we're all under such intense pressure, right, for length of stay and readmission. I think everyone in this room can appreciate that. One of the things that we look at intently is the social determinants of health. And in the absence of a clear complication, it seems like that's the top 9.5 causes of readmission. And I think the better that your healthcare team is, the more they do for the patients, and then the delta between the hospital and home becomes even greater. So I was surprised that I didn't see that on your table.
That's a great question. That was in the model. We didn't find any difference. We controlled for income, median income, based on census tracts, as well as distance from the hospital. And there was no difference. But I think that you have a great point, because especially this population that's like super vulnerable, they operate and then get home that's like 3 hours away from the hospital right away after they get outside the hospital. They don't stay, for example, in a hotel close by to the hospital. So I think that's a great question. And most of the projects we run, we always put in the social economic variables in the model. In this particular one, I didn't put in the tables just so it didn't look too busy. But we did look into that. There's no statistical significant difference.
And now that AMCs are becoming so busy and the census is so high, are you confident that you're capturing all the readmissions and they're not occurring at their local community hospitals and you might be missing them?
I'm not, actually. I think that's a great question. I think most of our patients, you know, they kind of fall outside of our network in this sense. So this is one of our projects actually looking at this, how, you know, information, for example, for chemotherapy, we have a hard time capturing this information because they go to tertiary centers and get not tertiary center, but they go, you know, they go to other centers to get the chemotherapy. So that's definitely a limitation in this sense. And I agree with you. Yeah.
Right.
Thank you. Excellent paper.
Thank you really much.
Thank you, everyone. This was a great session, lots of stimulating questions and data. So thank you.
Thank you, everybody. It's been a great morning, and you'll be surprised to know we're basically on schedule. After all what I told you about longer and longer discussions, we're on schedule anyway. We're now going to lunch and the posters, so please remember to put some time into the posters. Thank you. Good job, Mike.
Yeah,
It's great to see you. Yeah, thanks. Good to see you.
yeah, healthy, doing well.
Yeah,
Life's good.
I recently retired.
Yeah, I heard that.
Yeah.